Good afternoon, everybody, and thanks for joining us for a Bearing Point webinar today. Earlier this year in June, the NHS long-term workforce plan was released, and the aim of the long-term plan was to set a strategic direction for the NHS workforce in England. So what we're aiming to do today is just explore some of the elements that sit within the plan, and to more broadly draw on our experiences from within the work we do with Bearing Point in order to look at ways forward and how we could use the plan to have the most positive impact we can. I'm really excited today to be joined by Leanne and Lexi, my colleagues from Bearing Point. My name's Adam Morris. I'm going to be chairing the webinar today. I'm just going to hand over to Leanne and Lexi for some introductions and a bit of a personal perspective why a focus on workforce is so important to them. So Leanne.
Thanks, Adam. Yeah, really pleased to be here today because healthcare, social care, it's a people business, so workforce is the most important thing. It's the biggest asset that exists. So it's a really important topic, and personal experience as well makes it all the more kind of acute. So I've got a particular interest, I would say, in the opportunities that integration provides. I think the same, we need to make sure there's a good supply for the demand. That's for sure, and that in itself is a task and something that needs to be done. But I particularly am interested in how we use the workforce that we've got more effectively beyond the kind of the improvement programs of the past. So yeah, that's going to be my kind of perspective on today is the workforce utilisation and how that can change, differ, and how that actually can support the morale of the workforce and keep them in the workplace.
And I'm Lexi. I'm one of the managers in the healthcare team. I think for me, I also come from an industry background like Leanne. I've worked in the NHS, and there's huge opportunities to support our workforce in the NHS better than we currently do. I think for me, one of the key enablers that we'll talk about quite a bit through this is how can we get technology in a way that better supports our workforce. For being someone who works on a lot of digital transformation projects, I think people are arguably the most important part of making a technology project successful. We need to make sure people are empowered and confident and skilled in using systems. Otherwise, you can have the best system in the world and you're not going to realize the benefits that you need from it. So I think bringing the users along the journey with you with any kind of digital transformation is so important, and making sure our workforce are really comfortable and that we design systems in a way that they can properly use them and have that better relationship with their patients and have that better kind of empowerment to make clinical decisions. It's a hugely important part of supporting our workforce and will be increasingly going forward.
Thanks very much, Leanne and Lexi. Really excited to explore the topic today. My background is in defence healthcare. I've workforce planned and managed workforce at sort of tactical, operational and strategic levels over the past 20 years or so. So it's a topic that's really close to my heart. And today what we're going to try and do is explore the plan really from a person perspective, both in terms of the workforce that sit within our healthcare services, but also from the patient's perspective. So I think we'll start by looking at why it's important. There has been a lack of workforce against a perceived demand over recent years. We know that there's lots of competition in the labour market. We have an expanding sort of private healthcare sector within the UK, and policies around international access to healthcare workers that have constrained us somewhat over recent years. We're also contending with long training pipelines, and as a result, the plan addresses short, medium and long-term strategies in order to improve the amount of workforce available to the NHS. The plan largely addresses these issues at a strategic level, but it does talk about devolving that responsibility down to regional and local levels, and we'll talk about that to a certain extent as well. The three main focus priority areas within the plan are train, retain and reform. But instead of talking about those specifically, we're going to explore those through a number of lenses. The first lens is around enabling patient-centred care and what it means from a workforce perspective to feel their value in relation to delivering that care, and how integrated our systems and our organisations need to be to deliver that. And secondly, we're going to talk about data and technology integration. From a workforce perspective, how easy is it to adopt the use of data in a way that allows us to improve the care delivery that we have, and how can we take on rapidly evolving technology and innovation in order to support that. So to start with, we'll look at patient-centred care. And I'm going to hand over to Leanne initially to really look at her experiences in relation to patient-centred care and the things that often go a little bit wrong but can be improved as well through our activities.
Thanks, Adam. So I think it's really interesting when we think about the workforce, because we have struggled to recruit, and we've struggled to retain, and the work that we've done at ground level. So to park in the strategic picture for a moment, and the kind of needing to train, the allied healthcare professionals, etc. Actually, when you're on the ground, the reality is that those people are driven by their values. They're driven by what matters to them. Nursing, care work, working in those types of environment, health, social care environments, it's a vocation. So people are driven by those values. But what we've done over a period of years is we've we've over processed everything. Now that in turn isn't great, and has shown itself to definitely not provide great outcomes for patients. And there's lots of data and reports and all sorts of reports in support of that actually the way we now deliver healthcare means there are more touch points for people, and they get suboptimal outcomes. But what it means for the workforce is that we are restricting their autonomy. We're taking away their ability to work in a way in which they have been trained, in a way that gives them a sense of satisfaction. We saw this recently. We were working with a system at an operational level, at place level, and working with a healthcare partnership. And we spoke to a number of district nurses who were utterly frustrated at the inability for them to really holistically look after the people in their community, because we've done what we thought we needed to do to manage demand. So we've specialised services, and we've tried to siphon off bits of work to happen over there, and siphoned off another process over there, and to kind of grapple with this kind of perceived demand. But actually what we're doing is we're kind of dividing up the support that we're providing for an individual. So that means that their health and well-being is being looked after in silos, and the effect of that is that you now have very well trained nurses who are compassionate and want to help people, utterly constrained by a process, by a criteria, by it not being for that particular part of service and needing to be handed over there, and you're seeing referrals going off everywhere. And so it's twofold. It's not great for the individual patient, and it's not great for the staff, because they just feel like they're trying to do their job with their hands tied behind their back. And actually, when you look at something like district nursing or community nursing, as it's rightly now called, they know their community, and there is a strategic kind of goal to bring things back to neighbourhoods and integrated teams. But there's a way to go for that, and I think if we can keep working on that, and if we can start to look at our patients, our adults differently, and look at their needs holistically, we can build a workforce around that can be used. So the same number of workforce used differently, and in turn they'll get better outcomes, and the workforce will find themselves much more satisfied by the ability to look after somebody holistically, and not just keep only being able to refer on to the next bit.
Yeah, Yeah, completely agree. And I think just to build on a couple of the points you made there, I mean, one thing that is so important when we consider our workforce is to take that system perspective. It's for so many years now it's been kind of within providers, how do we best use our workforce, but actually we've got this one pool of resource across the system, and health and social care as well, and wider as well. Our blue light services are all of the kind of parts of the system that make up the carers for our community more generally. And actually taking that kind of system view and zooming out a little bit more means that we can have a look at our workforce as a pool, and really see about how we can best use them to focus on each patient. I think the other part for me that's really important is, we talk a lot in what we do about kind of target operating models and building what that organization view looks like, and actually keeping the patient at the center of that, of the real focus. We can then use each of our lenses that we talk about, but actually make sure that each one is focused on the patient and focused on how the workforce can then in turn focus on the patient through what they do, and not in all of the, as you say, the kind of wraparound and the rigmarole that they end up getting kind of sucked into. And I think we talk a lot about going back to the kind of technology. It's about how can we get technology in place that enables our workforce to best support patients. How can we, with governance as another example, how can we set up our governance in a way that has the right roles and responsibilities and accountabilities for people in our workforce, again with the patient at the center of all of those. And we could go through all of them. Our performance management is another really good example of where so often we end up creating metrics and KPIs that are, we think in theory are the right things to do, but actually there's no real traceability back to the impact that each one is having on the patient. And I think for us, with our, when we work through those types of organizational models, whatever we want to call it, it's so important that we have the patient at the center of what we do, and everything is designed around that kind of patient-centric, user-centric perspective. I think again, when we'll talk a bit more about technology and digital requirements in a little bit, but having the patient or the user at the center of those is such a critical part of any kind of healthcare, social care design work that we as consultants or our clients as service providers undertake.
Yeah, just on the performance measures, I think that's so true. So much of what we measure is a perverse incentive, and that's where we find the workforce utterly frustrated, because they feel like they're driving to achieve something that to them holds no value. So they want to know each day that they've provided some value to the people that they've seen. And a lot of the targets or the measures and the metrics that are used are actually not about the impact to the individual patient, which if you came into nursing or any healthcare profession to make a difference to people, actually they constrain your ability to do that, which is really, really tough when that's the thing that you're measured on, and that's the thing that tells you whether you're doing well or not. And that's where we've started to see a misalignment with the workforce against that kind of driving those kind of behaviours.
Yeah, and I think one other reflection of that actually as well is in the national data set that we're being asked to provide as providers. I mean, there's I think there's been massive improvements in what people have been asked to provide to NHS England and the like, but actually there's still a bit of a gap in terms of what you're being asked to provide and actually the meaningful business and clinical information that you and your workforce would probably want to be capturing, and I think there's a really good almost challenge for NHS England and the overarching leadership here as to how can you make sure you're asking the right questions that, as you say, connect it to what the workforce actually think is going to impact patient care and patient delivery.
Yeah,
fantastic. I mean, some really deep insights across a whole range of factors there, all the way from what motivates people initially to have a healthcare career, and a lot of time it's for that human interaction, it's the feeling that you can do something positive with your day, all the way through to how our organisational design limits often the ability to have that impact, and then overlaying culture and leadership over the top of that in order to to set the right conditions over time to do that consistently. I just wonder, in your experience, where have you seen good examples that you could draw on where those things maybe have come together really well in order to create that sense of identity and value for the workforce in a sustainable way?
So I think we've worked with clients in the past that have worked on integration at ground level. So, for instance, care coordination centres, which is a kind of evolution of a single point of access, if you like. So, turning it from being something that's really transactional to something which is about bringing together the system to think about how best we can provide support to somebody. Now, that requires culture change. That requires operational, process change. It is a huge undertaking, and that can't be underestimated. And on that note, I think one of the things that we see repeatedly when working in health and social care is that change management, that cultural change, that kind of behavioural science type side of stuff is often the thing that is not valued. It's the thing that can potentially be left out of a statement of work. It's the add-on. But actually, if anything, particularly at this time where we are making a real culture shift, because we're moving from health and social care and everyone kind of doing their work with their vision to a single vision. So it's a real mindset change. It's such a shift in the way we think, the way we tackle problems, the way we work, we measure, all of the kind of operating model lenses that Lexi talked through, the governance. And that doesn't happen by just having a new vision statement or having a new strategy. That happens by on the ground coaching. It happens by taking people along the journey. It happens by including them so they're part of the solution. It's genuinely owned by everybody. It's not an add-on. It is an absolute key enabler of any change. And we've just unfortunately seen repeatedly it be left out. And the reality is, when that's the case, even if a change happens to a process, eventually it reverts to type, or the workforce don't see the purpose, they don't see the value in the change, they don't understand why they've had to do it, and so morale again drops, motivation drops. So there really isn't a positive outcome of not working with people, and it means it might take a little longer, and it means you might have to take things more slowly, but it's absolutely the thing that will sustain the change going forward and create a workforce that is resilient. So because we will the NHS has had to and will continue to evolve and change over the years, and we need a workforce that is up for that, that's resilient to that is built for that, rather than one that has process change, process improvement, different things thrown at it and told to do it without any of the stuff around the outside. I think leadership, coaching, absolutely key to making the change. I don't know if you agree.
Yeah, I completely agree about the importance of that kind of wider change management, bringing people along. And I think one example that we've worked with recently where this has been done really well is a community mental health trust. They have done a fantastic job of really engaging the community, and they've engaged their staff and they've engaged their workforce, and they've said, what do you think we need to do to make our services really, really good? But they've also engaged the community. I think it's been a really fantastic way of just looking at what they've done, and they went out to different groups that are potentially vulnerable or hard to reach groups, especially for mental health services, where we know there are really specific challenges and stigmas associated with receiving kind of equitable care. And they went out to those groups and the community leaders and said, we know that it's difficult or more difficult for people in your communities to access mental health services. What should we do in order to better engage people and to draw people into services where they need help? And they had those conversations. And again, it wasn't some kind of small team of either senior leaders or a specific project management team. It was the actual people who were going to be delivering care who went out and who had those conversations, and they made space and time for them to be able to do that, which I think I haven't personally seen, and especially mental health delivery before. and that workforce actually went out and had some of those conversations and were, I think, much more empowered then to stand up and say, this is how we should be designing this model of care. This is how we should best access our community and be on the high street and be really accessible and have this kind of open doors. You'll see someone. It might not be the most qualified person initially, but actually you will see someone who can meet you where you are, who has experience of potentially of the kind of conditions that you're suffering from, and who can at least have that initial conversation with you a lot quicker than we've seen across other mental health trusts. I think that's one example of where actually getting the workforce engaged in the the kind of community aspect of it, and in getting them engaged in the service design, has translated into a model of care that's really, really accessible, and I think people feel quite passionately about, which is reflected in how they then deliver the care.
So I can clearly remember as a clinician both feeling pride in the personal outcomes that I was helping patients to achieve, but also when the system around the patient provided a really good wrap. That gives you a boost, and it motivates you. And if you were part of the development of the system in the first place, it's a really powerful model, isn't it? And as a result, we pick up on those nuanced integrations where people get lost in processes such as referral management and that sort of thing in a way that's really difficult to pick up on just by the routine reporting that often happens. I think we often see this concept of change fatigue having a really negative impact on workforce, don't we? My experience is that's often because change is poorly communicated. And I wonder whether you've got some examples where change has been managed well, maybe where the culture and the leadership has really delivered some of that effectively.
Definitely in small pockets, I would say. I'm not sure on a huge scale I've set a large kind of change program. I'm not sure I've seen it necessarily in health and social care, but definitely on a small scale. So I think one of the things that's really key is frontline managers, and I don't think we give them enough credit. So often we have to remember that frontline managers have found themselves there potentially by accident. They probably didn't go into their job. I certainly didn't ever go into my job to become a manager. And so perhaps if you're a nurse, it's unlikely you started nursing to become a matron or to be a ward manager. You started because you love to be a nurse, and that was what you trained to do. But people that are ambitious, people that want to make the difference, that want to improve outcomes for people, make things better, make resources go further, will naturally find themselves in those positions. But it doesn't mean that they're necessarily equipped with the leadership skills, because that wasn't their training. But often we kind of just sort of say, well, you were a fabulous nurse, so you could be a great ward manager. People above that, we find, go on management programs and get management training and things, but that real kind of front line, there is a gap. And whilst there has been some national programs and again pockets of different development, actually I think there is still an opportunity at that front line. Those people have got the biggest influence over the culture of a workforce, over the way that a workforce feels at the end of a shift, how they bounce back from a really difficult shift, how quality is managed. Those things are not from quality audits, and those things are all very important, but they are not the things that really drive the culture and drive people and the workforce. Or people leave. It's that typical thing. People leave jobs for a bad manager, because of a bad manager. They often will stay in bad jobs with a good manager. So that frontline management for me is where I've seen some real great pockets of change management, where the frontline leader has taken it upon themselves to make sure that they effectively communicate with their team, that they take them on the journey, that they're part of it, and that has worked really, really well. But yeah, on a large scale, not seen it yet.
Really good insights, thanks very much. I should have said at the start, and forgive me about questions, please, if you've got any questions, put it in the question chat, and we'll pick those up at the end. Lexi, I'm going to talk about the reform component a little bit now. I'd be really interested in your experience, because the reform component of the plan is very much about productivity. You know, we've got to put the right clinician with the right skills in the right place at the right time. That's part of workforce planning. You know, but then, you know, productivity is a more complex equation, isn't it? I think so. I mean, we've seen numerous times about the current skill sets that we've got, but there are some exciting ways that you can build a workforce for healthcare that aren't necessarily widespread. So, any thoughts on that?
Yeah, I mean, I think I mentioned earlier. I think you know, when we're bringing in digital tools and improved technology, there is a completely different skill set that's needed from the workforce. You know, we're expecting people to continue to do the same job in a way, but with a completely different set of tools. And actually, it is a different job in some ways than it would have been even 5, but definitely 10 or so years ago. And we need to equip our workforce to be able to do their jobs and to do it well and to feel confident and empowered. Because actually, the number of times, and I think back to when I worked in clinics, and the number of times you go around and you see the staff really struggling with you know, the system. Actually, that lack of confidence really translates. You know, they can be the best, you know, nurse or healthcare assistant in the world, but actually that lack of confidence really does translate into their relationship and their interactions with the patient, has such a direct impact. I think you know, when we are putting in new systems or even, you know, kind of evolving existing systems, we need to think about the impact that it will have on the staff from a, you know, from a training perspective, of course, but we can roll out, you know, all the user guides and manuals in the world, and if people don't have time and headspace to really absorb that, it's not going to help. You know, we've seen that so many times, even recently, where, you know, you would think we would be slightly better at rolling out digital change than we probably are as a sector. You know, there's so many more robust ways of actually delivering that. And it does, you know, private comes back to the change management, is having, you know, there's those kind of change champions within the organization who can actually, you know, be on hand for staff to go and ask immediate questions to when they're actually trying to do it. You know, a few more kind of interactive ways of learning and development and bringing people along the journey. And I think actually one thing I haven't mentioned, which I think is so important as well, is having users involved in the design of systems from the beginning as well.
I was just thinking that, yeah.
I mean, I'll hand over to you in a minute, but I think that you know, that kind of fundamental, how do we build our healthcare solutions, our digital tools, and I think going forward it's going to be even more important as we try and get to a point where technology is actually doing more than ever before, and we think ahead some more maybe things that probably aren't very far in the future around AI and virtual reality, those types of things. It's going to be even more important, and the risk it's going to be even more heightened if we don't get it right, to have you know, the solutions delivering it in the right way.
No, you took the words right. As you were saying it, I was thinking that although I think there's been an improvement in recent years, digital still kind of sits somewhat to the side, doesn't it? Digital, you know, in the healthcare space generally, to the kind of operations, if you like. And I think it's really important that digital solutions or digital enablement is driven by operations. I think as an operational person, I definitely would need help to understand the art of the possible. Digital's not my personal space. So, you know, I would need to be, if you ask me what I want, I'll tell you what I know exists. So I do need that support to understand the art of the possible. And it's about making sure you take people on that journey when you consider what digital enablement you're gonna work towards, so that those operational people that are there day to day actually help configure something that genuinely makes a difference, and makes their day easier, better, makes the patient outcome better, rather than, you know, a digital team coming in and gathering some requirements and developing something and giving it to operations, which is kind of what we've seen historically.
I think, you know, with that kind of market engagement piece, involving your workforce in that is so important. You know, get your nurses and your doctors and your ops leaders and you know, get your receptionists to be the one who's actually looking at the system that they are going to have to use at some point. Get them in the room and you know, all of these suppliers who work in the NHS with digital tools will all be more than happy.
Yeah.
They'll probably
Yeah.
you'll probably never stop getting emails from them if you ask
feet.
for a demo. But actually set up those demos and get your staff in the room and show them what's possible. And even if you don't think you've got the right, kind of initial, funding right at your fingertips to do it that year, start thinking about what is possible and the ways that you might need to change your business processes in order to actually adapt some of the solutions ongoing. But yeah, we've done a few projects recently where we've done quite a bit of that kind of market engagement, and it's really, really interesting to see how the workforce, at different levels and in different parts of the organization react to some of those demos. We did a set of demos recently with some digital social care providers, and had a lot of the adult social care providers in the rooms, and this kind of it is that thing about the art of the possible and actually seeing what they can do. And I think it reduces at least some of that nervousness around being actually involved from the beginning as well, because that kind of digital confidence piece is really, really challenging. And as I said earlier, it's not just about the training, it is about actually being part of it and feeling like it's not, I mean, I'm quoting you now, you say this all the time, but it's not doing it to them, it's doing it with them. And I think that's so important with digital change.
Yeah, and I just, sorry, another point on digital. So we've got digital and then we've got data, and I think so. There's opportunities in the future to support how we use our workforce, or both from a digital perspective, and from a data perspective. And I think going back to my integration driver, I think we can, with the advent of data warehouses and data sharing and ICSs, etc. I think what we can really start to do now is collect data and use it differently. And we know it's challenging. We worked for 7 weeks solid with trying to get data protection, a data sharing agreement across a number of system health care partnership providers. But we did it, and we got that data sharing agreement in place, and we collected the data, and we used that data differently to understand the demand, which then in turn gave the system an opportunity to think about how they respond to that demand using their workforce. And that is how we start to think about being fit for the future. People's health and social care needs are more complex now, and what we found actually when we did an initial kind of diagnostic piece was that you could have all the workforce in the world, assuming you had no limited funds, and you could create as many services as you want. They'll all get sucked up. They'll all get used. It's a never-ending. The way the system is designed to work means that generally the same people will just be siphoned off and use a number of different services, and there'll be duplication across the piece, and it will end up with these people just following a process, referring on. But actually there is an opportunity to now use data as a system, pull it together and view the world differently, and then that provides opportunity for actually genuinely using the workforce in an integrated way. Integration is still quite strategic, I think it's fair to say. Integration is more than people sitting in a room together. Integration is more than people ringing someone to say, do you know Mrs. Smith? It's way beyond that, and the opportunities are colossal if we can start to think about it. And I think from a workforce perspective, with a social care background, it provides a whole career path for care workers that previously didn't exist, and maybe that will attract new people into the profession that previously would never have thought of it as something possible.
So we sort of start to observe a really interesting cycle where you've got your clinicians and you invest in building both confidence and competence, in the systems that they need to use. The quality of the data improves in those systems, and then your faith in the data, to support decision making also increases, which is and the workforce benefits at every point. Then in the cycle, because confidence in the data you're seeing to make decisions is hugely important, but also not feeling vulnerable when you're using new systems and technology, is really key. I mean, you talked a little bit about the skill sets and the people that are coming in, and we're seeing lots and lots of trusts and ICBs redesigning their operating model and re-looking at their pathways. In defence, one of the ways we improve our workforce is by using apprenticeships. And apprenticeships, often provide vocational training, slightly shorter training pipelines, and they support areas in clinical pathways that there's really high demand really well. Now that comes out loud and clear in the reform, and the train component of the plan. I wonder in the NHS whether we really see apprenticeships being adopted at the moment. Just would welcome your observations on that.
I think it has increased in the past few years, but there's so much more scope for apprenticeships and I think generally as well for non-qualified staff. There's so many more roles, but I don't think we see them being adopted as much as they could be. And actually, there's a huge opportunity there to increase increase our kind of diversity of roles and how we use different types of workforce in a way that's as maybe not qualified or not registered, but is really highly skilled and really good at what they do. And I think we see some examples of that in occupational therapists and some of those maybe more traditional non-registered roles. But actually, there's probably so much more that we could do there, as you say, that point around the kind of shorter timeline to getting trained and actually ability to, in some instances as well, to kind of learn on the job a bit more and be actually involved in the workforce. And we know for a lot of these positions that is the way that they're going to learn faster as well, as just getting involved and stuck in, and then that starts to kind of plug some of our workforce gaps immediately. And it's absolutely an opportunity we should be looking into. I think one really important thing, and you touched on this, Adam, is just the point about making sure that the operating model is set up in a way that will properly embrace these new roles. So having them built into your your full kind of organizational design, that you're really clear about roles and responsibilities, what people can safely do, what's appropriate to entrust to non-registered clinician or staff, and where maybe some oversight is required, those types of things. But also kind of having those multidisciplinary teams that are set up in a way that they can provide the kind of rounded, holistic patient experience that we've talked about.
I think apprenticeships, they are increased. I think they're difficult to manage, aren't they? Because you're managing risk. There's lots of as an apprentice years ago, it was brilliant. The exposure I got to things which helped shape my career and what I wanted to do and what I didn't want to do. So I think they're absolutely fantastic. I think they particularly give exposure to careers that you might not, certain demographics, social mobility might not have access to if they didn't go down the university route and things like that. So I think they're great, but I think traditionally they're more tricky to manage, and it's really hard to ask a workforce that are already firefighting or feel like they're firefighting, and are firefighting day in, day out. They're hard, they're up against it, demand is high, to kind of invest in the future, even if kind of they know that's the right thing to do. Actually, on that Monday morning, that feels really difficult, and that then affects the experience of that the apprentice has. So I think it's tricky. I do, like you say, I think there's been an increase, and I think from people that I speak to in health and care, that those challenges are kind of what I describe as kind of what is fed back to me. They know it's the right thing. They want it to happen, but it's just another thing, and it's just some more governance we've got to get through, and it's something else. But I think, to your point, Lexi, I think finding a space for these apprentices and where they can safely work and things is key, and that's where using the data to understand how we're supporting people and what the opportunity is to do. So if you think about ARS roles that are used currently in PCN's primary care, social prescribing type roles that are not, they don't require a degree, but they require really great experience, people that have probably, worked in and around health and social care, and the ability to actually just just support people on a human level. That's a great example of where we support people as an alternative to clinical requirements and demands, because those people would have historically gone to their GP, but actually we can provide them with something better for them by understanding their needs. And I think if we can continue to collect data, understand people's needs, we'll continue to see opportunities like the R's roles to use a workforce, introduce a new element of the workforce and use what we've got differently.
I mean, just to add on to that quickly, that the R's workers, the impact that they've made in mental health is incredible. And I think seeing, you know, that shift from either from you know, primary care into the community, or actually even from acute into the community now as well, with some of the shifts from the acute mental health teams into the community, is you know, it's meeting people where we should be, and instead of driving them into their either their GP or into hospital unnecessarily. One point actually that you've just reminded me of there, and I think they mentioned this in the plan, but it's something that we're seeing increasingly. You mentioning coming from social care background and going during apprenticeship. One real risk with this is that we are going to end up competing almost for the same pool of resource across health and social care, and I think that's something that needs to be managed at a system level. There's no easy fix for this, because actually it is the same pool, but it goes back to, I think actually we should view workforce across the system, and especially when we're thinking about, you know, people coming up through apprenticeships, you know, the same types of skills and the same types of personalities and attitudes that we'd be looking for in you know, our social care carer roles would be the same types of people we would potentially be looking for kind of healthcare assistant roles. And actually, you know, that's going to start getting to a point where we are feeding across those two pools of well, one pool for the two different parts of the sector. And actually, again, it's an example of where we need to manage that integration of in terms of workforce and people.
I mean, another area that sort of sits in the middle and to the latter end of the career are those choices around the pathways that you can take to further your career. So we sort of consider the front end, don't we, of the career a lot there. But one of the things I've observed is that choice around where you take your career, you know, at the moment is leading to a highly mobile clinical workforce across multiple different sort of provision settings. So it seems hard for single trusts to keep people and develop them through their entire years. And I think for workforce planners going forward, thinking about those pathways, you know, more holistically, understanding what motivates people at different points, you know, and building some models that manage outflow in a much more managed way than perhaps they are at the moment will enable trusts to build the data around what's happening with their workforce so that they can mitigate some of that risk a little bit more.
Yeah, it's so true, because you do see people move around, don't you? And actually, I did a study years ago now, but we looked at the amount of workforce that was out of work just because they were moving from one trust to another, or one care provider to another, and it was a really high number. You know, it was coming up on a third of the workforce that at any one time was either outside or within an induction of a new trust, etc. I don't know how that stacks up now, but actually the workforce is becoming increasingly mobile, particularly post-COVID with hybrid working, and you know, just how our lifestyles have changed completely. So yeah, I think that's a really good point.
Yeah, no, I mean, the bane of my existence, I worked in clinics, was trying to get people all of their checks refreshed for doing the exact same job that they've been doing for 20 years.
I feel and getting them to complete training that
they've already done. With a slightly different banner on it. Trying to make all of those different workforce enablers more transferable and more standardized would be such a good way of kind of supporting our workforce and giving them a bit more options as well in their career.
I mean, there was some work on the passport, wasn't there? The NHS passport, but I don't know. I haven't worked in that particular area, so I'm not sure how widely that's utilised. I suspect not very much, just given that in all our work, none of us have really come across it. So that probably answers the question. but there's something about actually what does that look like for a healthcare partnership, like a place, or what does that look like for an ICS area? Is there some way that, because they've got the same problem, they're competing for the same workforce, and if you badge a job slightly differently with a slightly differently, hourly rate or terms and conditions, it can make people sort of move, and actually there might be a way to better manage that if you take a system approach.
Definitely, and we're seeing that emerging demand for almost a common workforce operating picture, where at the system level you can look across multiple provision areas and make sure that you're resourcing clinical pathways, in a way that they couldn't previously. Fantastic. So really appreciate your insights today. I've been monitoring the questions. We don't have any at the moment, but I think if I just summarise some of the conversation today, we think it's important to remember what motivated people originally to go into a career in healthcare, incorporate people in design, and really work hard to get those operating models and those clinical pathways aligned so that we are creating a real sense of empowerment within them, and within that we're training the confidence and the competence into the workforce to use the systems that allow us to coordinate care effectively. Let's think about career pathways a little bit in terms of not just how we sort of prime the pump in the first training pathway, but also how do we maintain the motivation through career. And then I think, lastly, bringing all of that together is a complex, service problem to do, and building the capacity at the local and the system, and then at the national level, in order to be able to address that in a timely manner seems really important.
Beautifully summarised.
Thanks so much for your inputs today. I really enjoyed that discussion, and I hope it was useful to the audience.